Thank you very much, and thanks so much for the warm welcome and for inviting me. It's obviously a very long way from Brisbane. I was lucky enough to come a couple of days early, so it does feel like morning now, which is terrific. And it's a real pleasure to be in a room full of so many people who are excited about improving care of older patients. That's not working. So, actually there's a slide missing from that. So I'd like to just thank, as well as the regional program, thanks. It's not advancing it though.
It's advancing it up there.
Oh, but it's not on this one. Oh, that's a challenge. It's all right, I'll have to peer around.
It's not showing here what's on the screen.
No, it's not advancing it at all. So also an international problem. That's now the same one. Yeah, it's just when I advance, but it's not.
Press it where?
Yeah, I'm pressing it well.
There you go.
Nope.
So you want this one?
Yeah, I'm happy to do it on here.
Okay.
Okay, I should be able to do it this way. So, I also forgot to thank my sponsors at home. So I'm supported by Metro North Hospital and Health Service, and also by a fellowship from the Office of Health and Medical Research, as well as OSHI, which is the Australian Centre for Health Services Innovation. And of course, like all people, by a really fantastic, hard-working team back at home. So home is circled there on the little map of Australia. For those of you who are familiar with Australia, Brisbane's about halfway up the east coast. This map shows the previous round before our most recent reorganisation, also an international feature of health services, and it roughly correlates with the population of Australia. So Queensland has about 4 million people. All of Australia has about 14 million, so similar to the province of Ontario. And most of the population in Queensland live down in that southeast corner, so our health service district is actually the largest in Australia. So we live in a beautiful subtropical city and near to beautiful beaches, so between the Gold and Sunshine Coasts of Australia. And I work at the Royal Brisbane Hospital, which is a large metropolitan teaching hospital, about 900 beds. We don't do any post-acute care or long-term care, so that's all acute care beds. And really my interest in health service research began when I was a senior trainee, and we built this large new building. So capital works internationally, building new hospitals generally means limiting beds. So we ended up with 20% less beds. And so we had an opportunity to really look at the way that we were doing work in general medicine and introduce multidisciplinary care teams. And that formed my PhD and really gave me an interest particularly in outcome measurement and thinking about outcomes for seniors, because as a general internist, more than 2/3 of the patients that I look after are elderly patients, and most of the patients who have prolonged stays or who run into complications in hospital are elderly. So I don't need to be telling this audience really what the urgency around improving care of elders is, but we all know that they are the largest, they're the primary client of hospitals, but our hospitals still aren't designed for them. We know that they have worse outcomes, higher mortality, more complications, and that a lot of that is about this complex interaction between underlying frailty, comorbidities that accumulate during life, and the hospital environment itself and the care processes that are applied, and that there's good evidence that we can mitigate against those poorer outcomes by some really simple changes in the practices that we have. But that we are working with a group that by and large don't have a loud voice in hospital care, and that require advocacy from healthcare professionals in order to implement these important changes that need to happen. And I'd recommend to you this fantastic essay. So one of my colleagues who's a writer, a published writer, as well as a physician, and brings enormous eloquence to her experience, both as a user and a provider in the healthcare system, Karen Hitchcock, who works at the Alfred Hospital in Melbourne. And she, in this beautiful essay, writes really about how the problems that we're having with the elderly in hospital are really a reflection. Hospitals are really just a microcosm of our society, and that we have institutionalised ageism in our society, and that a lot of that stems from our fear of growing old and our fear of illness and our fear of death, and that to manage that we all turn away. And that is exaggerated in our hospital environments. And it's a really eloquent discourse on this topic that I thoroughly recommend. You can buy it online. So today I'm going to be talking about the general area of processes of care as part of this larger framework, and you'll see in some of the things that I say that these are certainly not clearly separated domains, and that when we think about processes of care we also need to think about those other domains. And as a physician and as a scientist, it's fantastic to have this topic, because this is really the evidence-rich area for senior-friendly care. So there's a lot more evidence about what we should be doing and how we might go about it than there might be for those other domains. Just as an example, here's a PubMed search that I did a couple of days ago for delirium, and you can see just under treatment of delirium there are 6,500 published trials now and more than 500 systematic reviews telling us what to do in managing delirium. And they've been synthesised into beautiful guidelines. So these are the UK NICE guidelines for managing delirium. There are guidelines from North America. We have some Australian guidelines, and these are all very readily accessible and distill that published information. And even more than that, there are fantastic toolkits. So the senior-friendly toolkit, I'm presuming that many of you are becoming familiar with. And this really distills those guidelines even further into everyday tools that health professionals and patients can access. And we have a similar kind of toolkit from the Victorian Department of Health in Australia. Now you can see in the kind of menu on the side, we can't see it very clearly, but the kind of topics in the menu on these toolkits are similar kind of topics. So they are the large geriatric syndromes: delirium, functional decline, falls, pressure injuries, incontinence. And we know that these so-called geriatric syndromes are really the pointy end of that interface between how frail you were before you came in, how bad the thing is that happened to you, and how well you get looked after in hospital. And we know that organisations often only focus on one or two of these things, but they're inextricably linked. So, for example, if you eat poorly, you're going to be at higher risk of delirium. That's going to be your major predisposer to falls. Fear of falling, both from the patient perspective and, of course, from the healthcare provider perspective, confines people to bed. They get deconditioning, pressure injuries. So these are inextricably linked concepts. But all of them can be tackled with some really straightforward strategies, and this is my personal distillation of the evidence. And really the things that we need to do as providers in hospital is to get people up and moving. We need to be fostering independence, so rather than pushing people to the toilet, taking the time to walk them. We need to be promoting oral nutrition and hydration, getting the IV cannulas out as soon as possible. We need to be providing meaningful cognitive engagement, not just the who I am and what day it is, but really trying to engage patients in conversation and discussion and meaningful things to do in hospital. And I think that's the overwhelming gap in hospitals. I'll return to that. And also promoting and assisting toileting rather than assuming that anyone over 65 should be in diapers from the day that they hit the hospital. So these are all really simple things, aren't they? In fact, I have to be very cautious here as a physician, but we could even call them basic nursing cares. But we know that they're not just basic nursing cares. And in fact, part of the complexity is that people from all disciplines working in the hospital, and I know that all disciplines will be represented here today, can have roles in various aspects of these apparently simple cares. And we know that even though there's good established evidence for them, they're frequently missed. And this is data from a very nice paper by Beatrice Kalish's group in Michigan. And it's data from over 4,000 registered nurses and nursing assistants who were surveyed about how frequently on their ward particular cares were missed. And there was a menu of about 20 different nursing cares that were provided to them. And this graph shows the proportion of some of the cares related to the domains that I've just discussed that were always or frequently missed on that ward for their patients. And you can see that they range from around 8% for setting up meals for patients who could feed themselves, through to around 1 in 6 patients for feeding while the meal was still warm, to 1 in 3 patients for walking patients every day. So these are quite commonly missed cares, and this contrasts with some of the other things that they asked about, so things like doing blood glucose levels, doing OBS, discussing discharge planning with patients, all of which were missed less than 5%. Less than 5% of people reported that they were frequently or always missed. So these are clearly not always things that are seen as central, and they're clearly things that can be seen as more difficult. And some of the characteristics of these compared to taking OBS and doing some of the other routine processes is that some of them are kind of unpredictable processes. You're not sure who's going to need help with their meal, you're not sure what time dinner's going to arrive, you're not sure what time someone's going to press the call bell to need to go to the toilet. And I think that that kind of unpredictability, as well as the multi-professional nature of some of the tasks, make them really very complex to accomplish. The other really interesting thing on this survey was that the closest thing I could get to in the cares for meaningful cognitive engagement was the one that's called emotional support for the patient and family, which really isn't the same concept at all. So cognitive engagement of patients didn't even figure on common tasks that should be assigned to nursing staff, which I find quite interesting and would be consistent. I'm just going to miss that one. Consistent with my experience. Now, Sharon, my apologies, you've got an extra S here. I did upload some replacement slides, but they haven't happened, but that's all right. So this is a knowledge translation cycle, because clearly the problem here is not that we don't know what to do, because we do know what to do. There's a fantastic evidence base, but that it's just really hard to make it happen in practice. So in terms of this knowledge translation cycle, we have really good observational data, interventional data to show the kind of things that we should be doing. They're distilled into guidelines, they're distilled into patient and clinician toolkits, but we still know that there's a problem with cares occurring in hospital. So for my talk today, I'm going to really focus on how we might address translating that knowledge, because that's really what this program is all about. And I'm going to share some of the experience that we've had in our program in Australia around how we might, what the nuts and bolts of adapting this knowledge to your local ward might look like, and how you might identify and address some of the barriers in a meaningful way, and how you might use data in particular to be able to do that. And then towards the end, if I'm not running out of time, I'm going to touch a bit on sustainability. And I'm also going to be presenting data that's not just quality improvement data, but also more robust evaluation data, because like Sharon, I don't think we should be doing any of this stuff unless we're sure that it's benefiting our patients. So I'd been doing quality improvement work in this area for a number of years. We'd run a project in reducing functional decline, a project in implementing delirium guidelines, and a program in trying to improve nutrition in elders. And we were taking the same tack each time, and it's really that kind of social marketing approach which works very well with health professionals in the short term. So we raise awareness and we do some education of the different disciplines, and we rev everybody up with some nice little competitions or visible strategies. And we focus on some goals which we measure and remeasure. And this would be standard approach to a professionalised workshop that makes them feel that they're unified and working with peers to try and improve an important problem. But what we were finding at the end of the project, when the money ran out, as it always does, was that it was very difficult to sustain those things. And that became then very frustrating for the people working on the wards, because we would have a fantastic improvement, we would publish the findings, and then it would all just kind of fizzle out. So 3 or 4 years ago, I got much more interested in how we might try and embed things for prolonged success and think about not just success of getting things into place, but how we might be able to sustain them better. And the framework that we came across was the Paris framework, which is written by some colleagues of mine who are now in Adelaide, Alison Kitson and Gillian Harvey. And it's an evidence-based implementation framework that states that successful implementation is a complex function of the evidence that you have, which in this case is fairly robust, of the context in which you put it and the facilitation mode that you use. And it made us think a lot about facilitation mode and move from a kind of doing facilitation where you come in with a toolkit and a plan and a set of strategies that the people on the ward are going to do, through to working with the ward to come up with their own set of strategies through a really careful process of data collection and reflection. And I'll show you what some of that looks like in our program. And so the integrated Paris framework, which is the sort of version 2 of this framework, also pays particular attention to the recipients, which in this case is both patients and carers. And by spending a little bit more time thinking in detail and in depth about where we're kind of trying to embed the evidence and why it's meeting challenges rather than kind of glossing over that and just pushing forwards regardless, you'll find that you get much greater stickability. So I'm going to try and illustrate this with some of the work that we've done. So to begin with, let's think about why it might be hard. In sort of generic terms, there's a lot specific about wards, which I'll come to later, but in generic terms, why it might be difficult about implementing these basic strategies. Well, from the evidence point of view, even though I've kind of distilled it down for you into these 4 simple things you can do, the actual published evidence is quite complex because these tend to be multi-component interventions. They often have to be evaluated in a slightly complicated way, and reading that literature can get quite difficult for clinicians if they're looking at the raw data. And more importantly, it often is fragmented across different outcomes. So there's a falls literature, and there's a pressure injury literature, and there's a functional decline literature, and there's a delirium literature. And if you happen to be a passionate advocate for one of those things, which in your hospital probably means you're leading that area, you might not be familiar with those other literatures at all, even though they interact. And so you might have, so we certainly have the position where you might have the falls people and the pressure injury people really coming at the same problem from quite a different mindset and presenting sort of complementary but different evidence and ending up competing for attention for the staff. And I see a lot of nods happening around that. So fragmentation of the evidence is a real problem. And this concept that I've called sense in practice, and there's a really lovely recent editorial in JAMA Internal Medicine that accompanies the most recent systematic review of multi-component interventions for delirium. And it talks about the knowing-doing gap in delirium. It says, you know, the evidence is overwhelming that better delirium care is effective. So either we're not doing it because people don't know or believe the evidence, which should become vanishingly less likely as more high-quality evidence is produced, or because people say, well, I think we're doing that. And I think that sense that these are simple strategies that are basic, so they're happening. Someone's doing them. I'm not quite sure who it is because it's not exactly my job, I think is a real problem. And it's a particular problem in the acute care environment because so much is happening. And there's a beautiful qualitative paper by Godfrey published a couple of years ago where they were looking at implementing the NICE guidelines and the HELP Hospital Elder Life program in the UK. And they did quite a lot of groundwork looking at using another implementation framework called normalisation process theory that really looked at whether delirium prevention kind of had a space in nurses' brains, basically in their sort of cognitive environment. And they found that even though there was quite good awareness of delirium as a problem, the concept of prevention just didn't gel, because the acute care environment is all about reacting to the latest thing that goes wrong because you're just in this incredibly busy environment. And I think this is one of our issues for meaningful engagement of patients on the wards, is that as a health professional working on a ward, man, it's interesting, isn't it? Like, it's really busy, your page is always going, people are always talking to you, there's so much to learn, so much to stay on top of, interesting people to talk to. As soon as you're a patient on exactly the same ward, what's the overwhelming two emotions that we have? One, scared. Two, bored. Okay, that's what it's like to be a patient. And for a health professional to feel that that's what the environment, when it's in the same physical space as this kind of busy, ratty space, makes it very difficult. There's this cognitive dissonance between what a ward looks like. And I think that that's a real problem with the evidence. So we can state the evidence, but it's not how it necessarily feels on the ward. So if we think about the recipients of this evidence, we're talking here about both the patients and the healthcare providers, the people whose behaviour we would like to change is what we mean by recipients of evidence. And again, Karen Hitchcock, my writer colleague, discusses this relationship as patients being brought in and shoved up against strangers as the clinicians with whom they require an intimate relationship. And I think that that's a really interesting way of sort of formulating that problem, because it certainly is, it raises a lot of issues. And in these kind of strategies between clinicians and older patients, there is this issue of who actually owns the problem. And one of the commonest things that we're told when we go to work with a new team and we talk about, for example, mobilising is, oh, well, the patients don't want to move. So there is this sense of whose responsibility is it? Is it my job to make somebody get up and walk when they're feeling sick and they don't really want it? Is it the patient's job? Is it the family's job? So there's that lack of clarity of ownership, and that you could actually have this as a mutual responsibility. And on a larger scale between health professionals, we see that a lot of these strategies actually cross traditional specialist and disciplinary boundaries. And boundaries are a really important obstacle to successful implementation. And we spend a lot of our time when we're first talking to a team just letting some of that play out, some of the squabbling about whose job it is to do what and who gets paid to do what. And no, I'm an occupational therapist, I don't do diversional tactics. So these are the kind of problems that you know you're going to come across, and that take a high degree of diplomacy, I have to say. And the other thing is this really poor visibility. So these are basic cares and they should just be happening, and we kind of think they're happening, and a lot of the time they are happening. So it's not always very visible. The plate of food that's put a bit out of reach is really hard for us to see when we're rushing about doing all the other things that we have to do as busy clinicians. So making strategies visible is very important. So then, in terms of the context that we work in, those problems are kind of escalated to the next level up. So it's unclear who might be responsible for an interdisciplinary intervention, like many of these are. And Barbara tells me that your teams here often consist of clinicians and managers, and I think that's a really important fundamental to this kind of implementation, is that you've got someone who you can escalate responsibility to, because it can be very difficult when you're working across disciplines. We talked already about how coming in with different kind of interventions, so we've got to do this falls planning workshop this week, and we've got to all be aware of our pressure injury rates, and we're getting data reports from different people every week. The nurse unit managers are absolutely hammered with all this data about you're not quite doing well enough at anything just at the moment. And clinicians really get fatigued by this, and they get sick of being told, no, it's medication safety this week. And I think that that's something we have to be really aware of, and I think that it's something that's really plagued a lot of our programs. Again, poor visibility, and how you might actually be able to measure some of these outcomes. How do you measure things that don't happen is a fundamental challenge. So this is the trouble with prevention. How do I say how many cases of delirium didn't happen on my ward because they didn't happen? And how do you measure things that might be relevant to different audiences? What is important for me to be able to tell my patients is happening on this ward, and what is important for me to be able to tell the chief finance officer is happening in my ward are actually very different things. They shouldn't be, but we know the reality is that they are. And that comes along with poor perceived fit. So at the moment, my hospital is all about NEAT and NEST, the National Efficiency Targets, so access targets, the 4-hour rule in the emergency department, and surgical waiting times. And, basically, if it's not about NEAT and NEST, it doesn't exist. And, of course, we all know that managing the largest group in the hospital in a way that's safe and efficient and timely is actually going to make more difference to those targets than anything else. But it's very hard for us to sometimes be able to communicate that because it's an indirect link. So all of that makes it sound pretty difficult, and no wonder we're all struggling with this as a problem, but we love difficult, don't we? That's what we're all here for. So I'm going to talk about some ways that we've thought about managing these kind of problems in our program. And I think on the portal is a copy of an article that we've published recently in the American Journal of Medical Quality on a program called Eat, Walk, Engage. And I'm not going to run into the details of that program, but basically it's using enabling facilitation, working with individual wards to get into the nuts and bolts, not just of these big problems, but really into what's happening on that ward. And I'm going to use some data to illustrate that as we go through. So the first thing is positive messaging. So that study I mentioned by Godfrey found that this whole prevention focus didn't really register. And so what we want to do is to have some positive messaging. I don't know how well you can read this, but this is some posters we've recently done for our program. So Eat, Walk, Engage, nice catchy tree around the 3 of those major strategies. We have wording here, helping patients. So this is explicitly about the partnership. It's not my job as a health professional or the job of the patient independently, but it's about partnership. And a faster recovery, so that this is about quality and efficiency. A large reference to the patient, and I'll come back to that in a moment. So comments from patients themselves about what is a priority. And then really just a little bit up here, 50% of patients need help with meals, which says, yes, there's a problem and why it might be a problem, but not the emphasis on, oh my God, everybody's malnourished in hospital, what are we all going to do about it, which is often the kind of messages that we have. So positive messaging, and we've got that across so our Eat, Walk and Engage areas. As the previous speakers have alluded to, patients are central to all of this, and we've found that it's very valuable, and one of the fundamental tenets of our program is you begin with data from the patients. So what we do is we go and talk to a dozen or so patients on the ward that we're working with, go along in the afternoon, find people who are over 65 and who are happy to talk, so it does select to some extent. And we talk to them about what their experience around these domains has been and what might be barriers and facilitators. And you can see that they come up with similar kind of comments in terms of barriers, so problems with workforce. So the things that the nurses said in that study I showed you by Kailesh, the barriers to the reasons people missed cares were not enough staffing, in particular not enough staffing assistance, difficulties with communication between team members, and not enough physical resources on the ward to do stuff. And you can see patients come up under the same themes. They say, I have to ask for help to walk and there's not always someone to do it, there's not always someone to visit me. It can be difficult getting moving because I've got these complex dressings and I have to sit around and wait while that all gets done, or I'm really worried that if I leave the ward, there's this real fear that the doctor will come, and if I'm not there, oh my God, that's the whole day. It's not like they're going to come back, are they? Bloody doctors, hopeless. And this difficulty with accessing some resources. Now, staff will tell us similar kind of things, but patients sometimes come up with really interesting and practical solutions. My favourite one is, we need beautiful blondes to play games with. I think that's a fantastic suggestion. And I know that the hospital here is using a volunteer program with students, so clearly this would be the dietetic students. Where I come from, they're the beautiful blondes. But also some really practical solutions. We'd like permission to move around the ward. I don't know whether you have here in pizza restaurants and things, there are restaurants that have those little buzzers that summon you when your meal's ready, and I think we should have the same for patients, so that you're allowed to walk around the ward and you'll get summoned if the doctor comes. That would be a fantastic innovation, wouldn't it? A better idea of what the routines might be, what time might the doctor come, so that I don't have to lie in my bed for 16 hours and see the doctor for 5 minutes of that, which is what currently happens. And some really specific things about resources that they'd like. You know, I feel really tired and not very hungry and I can't be bothered using my knife and fork. It'd be lovely if I could just have some chips or something that I could eat with my fingers. You know, great suggestion. So listening to patients is really important. Building your team is crucial, and really this is where we found that we've needed to invest the most work and the most time. Everyone knows what a successful team looks like. This is an Australian cricket team. I don't do sport, but you know, we do cricket, so this is a successful Australian cricket team. And you know, when you get to that point of success, everyone can see what that is, but we know that years of work goes into this leadership, deciding on roles, bickering and squabbling to get to that point. And it's something that really takes a lot of skill and this enabling facilitation that we talk about. And so talking to the team can be really tricky. Getting members of the multidisciplinary care team in a room, and we get them in the room about once a month, and the first discussions are always very tentative. Everyone's a little bit worried about what this is going to mean for me. Is it going to take a lot of my time? They're a bit suspicious. They're easily scared off. And you don't want to overwhelm them with information, but you want to start bringing out some of the issues from the patient perspective and from the staff perspective. Now, there are always going to be team members that actually don't want things to change. There are people that are very comfortable with the status quo, thank you very much. And this is a consistent and major barrier in implementation, is that there are people that are just, this is the way we've always done things, and using data to address that is important. And you also need to guide discussions, because it's very easy to have a rogue team member who will really derail what you're trying to do and will lead it off into this whole different direction. We had an issue when we were trying to set up some chairs at the end of a corridor, so we've got this lovely sunny window outside of the ward, of course, that, you know, patients could be sitting there but there were no chairs, and the physiotherapist was like, well, you know, we'd have to get this special chair because everybody has to be able to, you know, what if the arms are too low, and what if somebody sits in it, and what if they can't get up? And it was like, well, what if somebody else who actually could sit in it did sit in it and enjoyed sitting in the sun? And so you have to sometimes be prepared. It's that old 80-20 rule, isn't it? So there will be people that will try and make it too difficult. And of course, there are people that just want to go the outright biff. So managing conflict, so bringing out the conflict. I think if you're getting a situation where your nurses and dietitians are actually going head to head about whose bloody job it is to feed patients, that is a triumph, because that discussion doesn't happen. And if you can get your ward to the point where that's happening, it's really uncomfortable for everybody. But you will go away, they'll think about it, everyone will cool off, you'll go back and have a few one-on-ones with them, and you will come to a solution. So don't steer clear of conflict, it can actually be very cathartic. Measuring is something that I'm very passionate about, but you need to think what you're going to measure that's going to give you the information you need to be able to change. And this goes back to listening to our patients. And one of the things that we do, that we've done on a couple of wards early on, is this data around talking to patients. Well, is this important to you? And this is to counteract the argument that I mentioned earlier, well, our patients don't want to walk. So when we go and talk to patients, so this is data from about 20 patients on our vascular surgical ward, we ask them, do you think it's important, how important do you think walking is to your recovery? You know, so on a sort of Likert scale from very important down to not important. They all said, really important. A couple of them said, I can't do it at the moment, because they just had their leg chopped off, but we know that this is really important to getting better. When we ask them, the dark blue bars there, how important does your health professional team think that is to you? What messages are you getting, recommendations are you getting around these domains? We can see that particularly for cognitive engagement, patients think this is really important. It's really important I keep my marbles while I'm in hospital. It's really important I know what's going on, or I'm going to get depressed, or I'm not going to understand what the doctor says when they come around. But they find that health professionals almost never mention that to them. So this is really useful data to take back to the team to say, well, you're saying you recognise it's important, the patients recognise it's important, you need to be giving consistent messages back to your patients that you think it's important. So we also asked them what their actual experience with those things is today. So this is data from the first ward that we worked on, which the published paper is around, so it was my medical ward. And you can see at the beginning, so the light bars are from early March 2011, and we interviewed about a dozen patients each time, about every 5 or 6 months. And only about a third of them, this is early afternoon, said that they'd actually sat out of bed. All the rest had been in bed all day. And you can see that as the program progressed with these different interviews every few months, we could see an improvement in mobility and in sitting out. So more people said that they were sitting out. And even where we see gaps, we were a bit disappointed to see a tip down in this third audit of the number of the proportion of patients that said they had something to keep their mind active. But when we probed the patients a bit more, it was because there were more in that group who were visually impaired. So the things that we'd put in, books and DVDs and magazines and the daily newspaper, all of which took a fair bit of organising, were actually not appropriate activities for that group, and that made us then have to think as a team what we might do next. So this is a mechanism that we've used when we've got research funding or some board physiotherapy honours students. We use this technique called behavioural mapping. It's much more intensive, and basically we have an observer, an invisible observer, who goes around to every room in the ward, moves room every 2 minutes, goes round and round and round for 4 4-hour blocks during the daytime, and captures information on what position the patient's in, what they're doing, who they're doing it with, and whether they've got some activities. And it gives you really beautiful, detailed data. So each of these bars, again over 3 separate time periods, several months apart as we implemented our program, looks at the percentage of those observations, and there's about 600 observations in each one from these 20 patients, who were ever seen to be upright on the ward, including in a wheelchair because it's an amputee ward. And you can see that that increased from about 30% early in the program to about 80% a year down the track, and that corresponded with an increase in time awake that was spent upright from about 3%, which is really quite low, up to about 9%, which is similar to the amount of mobilisation that we see with accelerometry studies in rehabilitation facilities. So that's fantastic. Now, the interesting thing is that our patient interviews done at roughly similar times, but on a sort of much more convenient sample of 20-odd patients. So these interviews in the afternoon showed really very much the same, so about an increase from about 30% to about 80%. So my point here is that complex data is lovely to publish, but easy data that you get from your patients probably has enormous validity and has the advantage that you're actually speaking to people. I'm going to talk through this slide in a bit of detail. There's quite a lot on this slide, but this is another form of data we collect, which is mealtime audits. So we'll go around and audit 2 breakfasts, 2 lunch, 2 dinners on the wards that we work on. So breakfast is the dark bar, lunch the light bar, and dinner the in-between one. And these are 3 hospitals which I've de-identified because I love food. So the point of looking at this is to show how problems can be universal but also very specific to a ward. So these wards are 3 orthopaedic wards in 3 separate hospitals within my healthcare district that we worked on a development grant. And we measured a number of things, and the 3 I've shown here is, were the patients sitting out when the meal trolley arrived on the ward? Did they get assistance within 5 minutes for those that needed assistance, either with just opening packets or with actual feeding? And was their mealtime interrupted? So you can see on the first one, we have very similar pattern in terms of mealtime variation between the 3 wards. So we have a lot more people sitting out at lunchtime than other meals, and that relates to the classic ward practice where you give people breakfast, you get them up for a shower, you sit them in the chair for as long as they can tolerate, and then with any luck their lunch arrives before they go back to bed, and then they go back to bed for the rest of the day, all right? So that would be the classic practice. You can see this ward in the middle is actually almost nobody's getting out of bed, and this tells you that this is a ward with a really toxic culture around patient mobilisation, and it's a ward that we've been working with for some time. It's very slow progress, but we're finally making some progress with that ward. This is really interesting because on this ward we had 40% of patients out at lunchtime but nobody out at breakfast. So we could take that data back to them and say, this is interesting, what do you think's going on here? And they went, oh, well, that's easy. Our patient support officer, person, does the oxygen run at 7 o'clock. So he's never on the ward at breakfast time. So you go, so why does he need to do the oxygen run? I think that's getting cylinders of oxygen at 7 o'clock in the morning. I don't know. It's just the way he's always done it. So you can undo that as a system. You can suddenly have a porter on the ward at 7 o'clock because he's perfectly happy to do that at another time. It's not a time-critical task. It's just where it always has been done. So this data can make the ward see that this is a time-critical task and you can change practice. Similarly, with assistants, we can see here's a ward who have an amazing multidisciplinary model and a very strong dietitian who's driven significant quality improvement. We knew that about this ward, and they're right onto it. They're feeding all their patients. They drop tools when the meal arrives, and that's the primary focus on the ward, is feeding patients. Again, this curious anomaly on the third hospital, and you can see exactly what's happening here. So plenty of people sitting out, no one getting assistance, nobody getting interrupted. You take that pattern back to the ward, they know exactly what's going on there. Can you all see what's happening there? The nurses are going to lunch, aren't they? They set the patients up and they disappear. So this is absolutely graphic. They didn't know that they were doing that. They had no idea. So when you're asking the team, they're not going to give you that data, but you collect some simple data and suddenly you can see their work practices and they can see their work practices. So very useful. And this is an example of how you can't just come in with a toolkit, this is what we're going to do, blah, 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 because every ward functions slightly differently and you need to get inside and understand. And adaptation and ownership of the ward is very important. For those of you who don't know, this is the platypus, which is a curious little Australian animal, very well adapted to its environment. When it was first taken back to London, it was assumed to be a hoax, in fact, because it has the bill of a duck and the feet of a duck and lays eggs, but it's in fact a mammal that raises its young in its pouch. So, human resources is always the thorny sticking point, and I think that this is going to be a real challenge for you guys because a fundamental part of our model has been having an extra pair of hands, and all of the quality improvement projects we've done have required an extra pair of hands, and you can see an extra pair of hands has been valued from way back, this is Aboriginal rock art from thousands of years ago. And if you look at successful models for delirium prevention and other elderly care programs, they all have some sort of extra pair of hands, whether it's volunteers or a nursing assistant or a geriatric resource nurse or whatever that might be. But the important thing is that we don't just supply that resource to the ward and hope that they'll get on and use it in a good way, but we use this data and our in-depth discussions with the ward around how we might best target that resource. So we're working with an oncology ward at the moment, and they said, you know, we really don't have many staffing on in the afternoon, and we wonder if the assistant could come and do an afternoon shift here, and they could help with dinner and do some activities with the patients in the afternoon. But in fact, when we went back and did the meal audits, assistance with dinner was happening really promptly, and patients were being sat out for dinner, because even though there weren't many staff, there are very few competing activities at dinner time. And in fact, it was lunch, when the most staff were on the ward, that the fewest patients were sitting out because there was so much toing and froing from chemotherapy and radiotherapy and all those kind of things. So targeting the resource in the evening would have been a mistake, and we can use our data to target it to the right activities at the right time. And it's really important to work on things that are important to the team first and get some runs on the board and then think about some of the other things that might be important. I talked earlier about visibility of strategies. So these are some tawny frogmouths. You might not be able to see them there, sitting in the tree. Nice little Australian bird like an owl. So we want to make sure that what we're doing is visible at all levels. So we want it to be visible to patients, to staff, and to decision makers. And we've got some lovely flagship strategies. So we have an afternoon tea on the oncology ward that's run by the volunteers. That's run as a little high tea for the patients and their families. This is a group on a Redcliffe ward. Redcliffe's a small community hospital, and it's one of the orthopaedic wards we worked with. And they had a room that was closed because they were over budget with nursing. And so they were able to set up this room with some comfortable chairs for patients to go to and have a chat. And one of the strongest things we hear from patients is we'd really like a space where we can talk to other people who are going through the same experience. And certainly the move to more and more single rooms to protect all our patients from infection are a real challenge for this social interaction. So this was a lovely model. I think they must have been knitting beanies that week, because they all all seem to have matching beanies on, but providing some meaningful activity. They had a nursing assistant who'd spend time with them down there, and they'd go down there for 2 or 3 hours during the daytime. And this is a really, really unusual occurrence on an acute care ward. Visibility to the decision makers, to the money makers, is all about length of stay, isn't it? And I was talking to Barbara yesterday about the data that they've seen in the Move On program and how they were quite surprised to see the length of stay reduction. And we were the same. So we set off on our first ward with Eat, Walk, Engage. It was all about quality improvement and process improvement. And a few months down the track, the nurse unit manager said, "Have you seen our length of stay this month? It's really a lot less, and we're not sure what has happened." And so we were tracking length of stay, and we really showed this very dramatic reduction. So the red line is this medical ward. This is patients discharged from the ward. So it looks like a very long length of stay. It's patients over 65, and it excludes anyone who was discharged from all those holding cells that we have on the way in our medical assessment planning unit and our short stay unit, blah, blah, blah. The blue line is all elderly patients in standard wards across the hospital. So you can see over these 2 or 3 years that are mapped out here, we did have a small reduction in length of stay in the hospital as a whole. There are a lot of initiatives in our hospital at the moment, but this was really very much outstripped by the ward that we were working on. And the other interesting thing that it was really 9 months from when we started working till we saw this. So we saw the processes improving within 6 months of commencement and working with the team, but it takes a little bit longer for all those to click into place and actually impact on length of stay. And we're becoming more and more confident in this finding. We've seen it on 2 of the other wards that we've worked with, so we think that this is real. Not everyone's interested in length of stay. We have a very large safety and quality unit and an executive director of the hospital who's the sponsor for safety and quality, and it's all about accreditation and meeting standards. And so being able to show that so this is trend in pressure injury incidents over the first year and a half, where we're working with our vascular surgical ward, which is obviously a very high risk population. To be able to show a reduction in pressure injury was a very important finding on that ward. And the ward received one of the top quality awards for the hospital. So finding some visible strategies where you can reward your team for what they've done, find an award that you can nominate them for quality improvement, those kind of strategies. Presenting at grand rounds, presenting at nursing in-services, presenting at mandatory education sessions are all very important. So for the last couple of minutes, I'm just going to mention, thanks, I'm even on track, which is good. I'm just going to talk briefly about sustainability, and not because I don't think it's the most important thing, but because at this stage of your journey, it seems like a distant goal. So you've got a lot of this work with your teams to try and get change from happening, but you don't want to be wasting that time further down the track by it all slipping backwards. So by planning around the context and trying to change your systems rather than just the individuals, you'll get a lot more traction and a lot more lasting traction. But there are also some very specific requirements for leadership, and this is experience from the Hospital Elder Life Program, which is a very well-established systems approach to caring for older people. And experience from their programs and the programs that have lasted and the ones that have folded shows that there are 3 key features. The first one is leadership. So you need a strong leadership team, and that's why it's very important that you've got an executive leader on your team, and the higher up in the organisation they can be, the better. We have just moved from project mode to program mode for our Eat, Walk, Engage program, with funding to roll to 8 wards. And my steering committee consists of the directors of all the major divisions in my hospital and the director of allied health. So that gives us enormous traction within the hospital, and we're having very infrequent meetings. So I've told them that we meet 3 monthly. They're all pretty happy about that. I say, that means that I'm just going to make the decisions and you're going to say they're okay. They're all very happy with that. So you have to have a passionate individual. I guess that I'm the leader of the program. You have to have a team behind them, and you have to have executive buy-in. Very, very important right from day one. You have to have measurement for success and having a range of measurements that you can present, as I've shown. So things that are about those minute processes of care that really help with change, you can use to track improvement, and also sort of your large-scale metrics, looking at things like falls or pressure injuries or areas that you think your organisation might have a particular pressure point are really important. And finding ways to sustain measurement in the long term will be a really big challenge for you. I think you're a long way ahead with having some very specifically defined indicators here, but I think that is a challenge. And continual advocacy in every forum you possibly can, presenting to staff, presenting to patients, presenting to decision makers. Relentless advocacy, I think, is very important, and something that clearly the RGP here have been very strong with. There's always the evil lurking, and I think particularly we need advocacy. So that's a red belly black snake. My husband found a baby one in our yard the other day. I was very happy that was gone. So this is a wordy part of the executive summary of our intergenerational report. So I was very interested to hear your Minister for Seniors talking today, because this is the intergenerational report, which is kind of the economic blueprint for Australia for the incoming government. And you can see the words that I've highlighted there. This is the kind of insidious wording that we find using, that you know, this ageing, isn't it great? People are living longer, thumbs up, but this is going to be a huge problem. This is a burden. This threatens our prosperity. Imagine, my God, wouldn't it have all been better if they'd all died of infections in their 30s like used to happen? And you know, I think that this is really problematic, and so you know, hospitals are microcosms of the community. I think that you have a big advantage here in Ontario, where you've got politicians saying we want to be a senior-friendly state. I think that's a fantastic advance, but there will still be insidious ageism through all of your institutions that you have to be constantly vigilant about. And just in closing, I'm going to give you another excerpt from Karen's work, which probably gives us all the very strongest reason to be here and pursuing this work. Because old people didn't get there old, you know? They were all us, and God willing, that's who we're all going to be. And certainly when I get to that part of my journey, I'd really like our hospitals to be a better place than they are today for looking after me. So thank you very much for welcoming me to your beautiful city, and I'm really looking forward to working with you over the next 3 days in your exciting journey. Thank you very much.
Thanks very much. Dr. Mudge has agreed to take some questions. We have 5 minutes for questions, and we have 2 microphones in the room, or if you have a good projection, you can shout out your question. We can repeat it up here.
I've talked too much.
Can you comment? You highlighted the grassroots nature of the start of these initiatives. Can you speak to what kind of support you get within your organisation from senior leadership?
Yeah, so that was certainly a real challenge for us to begin with, and we were we've been going through a phase of major change, and so for example, in my health service, which is a network of 5 or 6 hospitals, we've had 4 CEOs in the last 2 years, one of whom is still under investigation by the Crime and Corruption Commission, and parallel to that, we've had 4 or 5 executive directors of the hospital. So initially, I had done the whole thing of going and explaining all these results to the executive director of the hospital and the CEO of the organisation. But by the time you're going back to the 3rd one, you know, 3 months later, you're just like, oh man, this is a waste of time. So that has really led to our focus being very much, let's just get on and do stuff at the team level. And it's really only now that we've got these runs on the board and some good data to show that we've gone back and we're trying for leadership through the organisation. So you have to be very aware of what stage of readiness your individual organisation and your individual ward is at to decide on your strategy. And deciding on an individual strategy, well, first we're going to talk to the executive director and then work our way down, might not be appropriate for every setting. So adaptation to setting is crucial, I think.
And I thought I saw someone moving up to get to a microphone.
No? I'll be around anyway. I'm more than happy to take individual questions during the breaks and all that sort of thing. Yeah, yeah. Yeah, sure. So the question was, what sort of format is in the questions that we go to ask the patients, and do we have examples of format? So we did this through looking at the literature. There's a number of qualitative studies that have come out, particularly around barriers to mobilisation in hospital, but also we've done some work around barriers to nutrition in hospital. And so we used that as a starting point, and I guess we've evolved our questions over time. So we began with this fairly simple format. How important do you think it is, these three things? How important does your healthcare provider think it is? What have you done today? What were the barriers? What were the enablers? As time's gone on, in response to the answers that we get, we've become much more sophisticated in those questions, and so we're trying to tease out more detail about, well, how far did you walk, what, those kind of things. So we do have a current format that we're using in the multi-site research study that we're just beginning. But I think the important thing is to just start with anything, because the answers that you get will inform the direction you should go. And we also respond to what the team might want to know about the patients or where their gaps are. So, for example, our vascular surgical ward were curious about pain relief, and we got this really useful information back from patients that, yes, management of their acute pain was really good, but actually nobody was paying any attention to their chronic pain and managing their back pain or their sciatica or the other chronic pain that they brought with them, and that was often disregarded. So that was something that we could take back into nursing education. So we tailor. I think the important thing is to stay nimble and tailor. We've had formal consent in our couple of research studies, but when we've been conducting this under a quality improvement umbrella, we just seek verbal consent. Would you mind spending 5 minutes talking to me? I think if you can get recordings, video or audio recordings of patients, which we're going to do in our next round of the study, that's really useful because the patients tell you just such beautiful vignettes, and trying to capture that in writing can be quite difficult. And I think particularly for nursing staff, the patient story is a very powerful form of evidence and for decision makers. So if you can play recorded footage of what patients are saying about their care, particularly patients' experience of delirium is very powerful argument for improvement. Yeah. Yeah, okay. So the question's about why we chose Eat, Walk and Engage. I wanted Walk, Eat, Think, but that would be WET, and we decided that wasn't a great acronym. So we quite like Eat, Walk, Engage because it's you, as in it's all about you, which is kind of nice. So really the three fundamentals, I think that we should have the other one, which is continence care, in which case we could call it Walk, Eat, Engage and just be we, and that would be easy for everyone to remember. But again, perhaps not great in your press releases. So I think it's a distillation of, the evidence is complex, and trying to pull everything into simple things that you could do, that we can present to every member of the healthcare team, from the intern to the consultant to the physiotherapist to the nurse at the bedside. These are what we want the patient to be doing, and it's then your job to decide on what your individual strategies and your team strategies might be to do it. And it's not fully comprehensive, but I think that it's always trying to get that balance between sort of completeness and doability that we're trying to do. So that was really where we chose those three strategies, because they're the key elements of all delirium prevention programs that are published. Yeah.
Thanks very much. Now, we're fortunate that Dr. Mudge is going to be with us for the next 3 days, so I know that there are lots more questions that people will have, and she'll be
Come and talk to me.
available to all of us. So thanks very much, Dr. Mudge.
You.